Right, I make it just about 1 o'clock. So welcome everybody. Thank you so much for coming along today to this Ovarian Cancer Action webinar. My name is Jo and my role at Ovarian Cancer Action is Cancer Prevention Officer. And that basically involves raising awareness of genetic testing, risk reduction options and so on. Today's topic is Lynch Syndrome. We've got a really good Q&A today and we're joined by Dr Anju Kolkarni from Guy's and St Thomas's. Just a little bit of housekeeping to start with about how the session will work. So in today's webinar, you'll be able to see myself and Anju, but not the other participants. Everyone's on mute just to limit background noise and so on. And also because we're recording this session today so that we can share this with you and also anyone else who may find it useful in the future. So please don't feel you need to take any notes or anything like that, as you will be able to watch it back once we post it to our website. On the bottom of your screen, there should be some buttons and you should be able to see chat and Q&A in there. Please feel free to ask any questions as we go along by using the Q&A function. We will keep those questions anonymous, so I won't read out any names or anything. So please do take advantage of having an expert here to ask questions of. I don't think we've got anybody on the phone today, so we won't need to worry about unmuting those guys. Just to let you know, this webinar is one of a series of workshops and webinars that we're doing as part of a joint Staying Connected project with Ovarian Cancer Action and Overcome Together. And we've got lots more sessions coming up, so please take a look at the programme on our website. We've also recently set up a monthly newsletter specifically for people with high genetic risk so that we can give updates on anything to do with COVID, screening and so on, research and guidelines. So please take a look at that as well. We've already got lots of questions sent in advance and I'm sure we'll have lots of more questions as we go along. So we will try and get all of the questions answered, but if we don't, or if you have something that comes up afterwards that you want to ask, please do just get in touch via the email that you got your invite on. So to introduce our lovely guest expert today, Dr Anju Kolkarni is a consultant clinical geneticist at Guy's and St Thomas's Hospital and leads the South East Thames Cancer Genetics Service. We're really lucky to have you along today, so thank you. Dr Kolkarni trained at specialist level in both medical oncology and clinical genetics, so hopefully she can answer all of the questions that you've got today. I do want to say though, as always with these kind of things, Anju is here to answer questions on all aspects of Lynch syndrome, genetic testing, cancer risk and so on, but this isn't a medical consultation, so we're not going to be able to offer personalised medical advice on your personal situation, so please do always consult your medical team about your own family history and medical situation. So thank you so much for joining us, Anju. I wonder if you could first of all tell us a little bit about your role and maybe a brief overview of Lynch syndrome, just so that everybody on the call is up to speed on the basics.
Sure. Well, thanks very much for inviting me, Jo, to join you today. So I'm a consultant clinical geneticist and my area of expertise is cancer genetics and hereditary cancer risk assessment. So I've been working as a consultant at Guy's and St Thomas's for 8 years now, and I've been leading the service, the cancer genetics service here for the last 3 or 4 years. As Jo mentioned, I have a background in both medical oncology and genetics, so that's always been where my interest and heart lies, so to speak. And I'd say in terms of Lynch syndrome, moving on to what that condition is, many of you may have an idea already, but Lynch syndrome is a genetic condition that can be linked to an increased risk of, in particular, bowel cancer, but also gynecological cancers and other types of cancers as well. Predominantly bowel and endometrial cancer risks in particular for men and women. So what we know is that Lynch syndrome was thought to be a relatively uncommon condition, but more recently it's becoming clear that it actually is present in a larger proportion of the population than we previously thought. Maybe as many as 1 in 400 individuals in the UK general population might have the diagnosis, and it probably accounts for around 3% of all bowel cancers really in the UK. So what we know is that it's a genetic condition that's inherited in what we call a dominant manner. So what that means is that people who have the condition have a 1 in 2 chance of passing on the condition to each child. And just because you inherit the mutation or the spelling mistake in the gene that causes Lynch syndrome, it does not mean that you will develop cancer. It just means that your risks are higher than other people in the general population who don't have Lynch syndrome, and therefore we may be able to put in place screening measures and chemopreventative measures to help reduce the risk of cancer for individuals who have the condition. I think that's probably enough of a background, is it, Jo?
Yeah, that's really helpful kind of first whiz through. Going into a bit more detail, we did have some questions sent in specifically about the different variants that come under Lynch syndrome and what the risks are, because we do know that not all of the variants have the exact same risk, do they?
That's right, yeah. So that's something that's come to light in the last few years, a couple of years, I'd say. So prior to a couple of years ago, we probably managed everyone who carried a mutation in one of the Lynch syndrome genes in a very similar way. So there are 4 genes that we currently know of that are associated with Lynch syndrome. They are called MLH1, MSH2, MSH6, and PMS2. And it used to be, like I say, that if you had a mutation in any of those 4 genes, you and your family members who carried the mutation would be managed in very similar manners. But it's become apparent that actually some of the risks are very different for the different mutations. And in particular, PMS2 actually has much lower risks of bowel cancer than we previously thought. MSH6, by contrast, is more associated with gynecological cancers for women. And so these are different, slightly different risk figures for men and women as well in terms of bowel cancer risk, depending on which gene mutation is involved in the family. So it's important that when you have genetic testing and counselling for mutations in these genes, that you have a genetic counsellor or a geneticist going through those risks with you, and we tailor the screening advice based on which mutation, which gene the mutation has been found in.
That's brilliant. That makes a lot of sense. Thank you. We did also have some questions about guidelines for genetic testing based on those who've already had a diagnosis of cancer. So on the topic of ovarian cancer, for example, if a woman has been diagnosed with ovarian cancer, should she be asking for a Lynch syndrome test as well as a BRCA test, or does this completely depend on her family history?
So it very much depends on a few things. It depends on her family history. It depends on the histology of her ovarian cancer, so what type of ovarian cancer she had as well. We know that the type of ovarian cancer that you see with BRCA gene mutations is very different to the type of ovarian cancer you see with Lynch syndrome gene mutations, so that can also help guide whether it will be the right thing to do. The process for genetic investigations in Lynch syndrome is slightly different to BRCA. So when we think about BRCA1 and BRCA2, which many people have heard of, and that's the breast and ovarian cancer susceptibility gene, we tend to go straight to the gene testing, whereas actually for Lynch syndrome, the majority of the time we will do some initial tests on the cancer specimen to look for almost like a screening test of the tumour itself to see whether it looks like it might be caused by Lynch syndrome. Now in the UK, there's been guidance from the National Institute for Clinical Excellence around guidance for that initial tumour testing on bowel cancers, and that's been in place for a couple of years now. And there's some new guidance being proposed for endometrial cancer as well, which is out for sort of consultation and being drafted at the moment. But ovarian cancer, we don't have that kind of guidance on. And so very much for ovarian cancer, it will be based on whether there's a family history of Lynch-related cancers as well in the family. So it wouldn't be that a woman would go and have BRCA testing and Lynch syndrome gene testing at the same time. It would be slightly different processes.
Okay, that makes a lot of sense, yeah. So similarly then, you mentioned that there's some new guidelines coming in for uterine cancer. At the moment, if a woman receives a diagnosis of that cancer right now or has in the past, and she's worried about this, what should she do? Should she be looking into her family history, or is this something that will be brought up by the clinician at the time?
Like I say, because the guidance is still just in process, I think if a woman's had endometrial cancer, particularly at a young age, so anyone diagnosed under the age of 60, I would say just speak to your GP or your oncologist and get advice about whether you need to have that initial sort of testing on the endometrial cancer specimen that can be performed. A lot of places are actually doing that as part of their process anyway for people who are diagnosed at a young age with endometrial cancer. So it may have already taken place, or it may be something that's going to happen. Particularly if you've got a family history of Lynch-related cancers. So just to reiterate, those types of cancers are colorectal cancer, so bowel cancer, other gynecological cancers, so endometrial cancer and ovarian cancer. Not so much cervical cancer, actually. Cervical cancer is not so much a genetic or inherited form of cancer. It's more a cancer that's linked to environmental exposure to a virus, the human papillomavirus. So it's really endometrial, ovarian, bowel cancer. Sometimes in Lynch syndrome, you might see upper gastrointestinal cancers or urinary tract cancers, but that's a bit rarer. With MSH2, you do see more urinary tract cancers. So it does, again, depend on what the family history shows as to whether a woman will get further investigations or not.
Okay, brilliant. And you've already mentioned colorectal cancer and that the guidelines have been in place for a little while. So just to be really clear for anybody watching today, if someone is diagnosed with colorectal cancer at the moment, what should be happening for them in terms of testing for Lynch?
It depends on the time of their diagnosis, but if they've been diagnosed recently, in the last year or two, then at the time that their specimen was examined under the microscope, most pathology centres should be in line with the NICE guidance, looking at that pathology specimen to see does it show features of Lynch syndrome. And one of the tests that is done, there are two separate types of tests that can be done, but the most commonly used one is something called immunohistochemistry, and that's looking for expression of the Lynch syndrome proteins in the cancer. If you see the Lynch syndrome proteins in the cancer, then it means that those genes are working fine, so it's very unlikely to be Lynch syndrome. But if you don't see those proteins in the cancer, then it suggests that maybe the gene's not being read properly, because normally what the body does is it reads a gene, like a book, and it makes a protein. And so you would expect if the gene was working and it didn't have a mutation, that the body could read the gene easily and make the protein, and you would see that in the cancer. So it's looking for loss of that expression of those proteins, that's what we're looking for in the tumour. And if we see that, then it might suggest that there's Lynch syndrome, but it can happen for other reasons as well, not just Lynch syndrome, that sort of change in the tumour itself.
Okay. We also had a couple of questions about different types of cancer, with people hearing kind of on the grapevine that certain other types of cancers might be linked to Lynch. So had a couple of questions about breast cancer and skin cancer as well.
Mm-hmm. So with breast cancer, I'd say the jury's still out really on whether breast cancer is linked. There have been some studies suggesting a possible link with MLH1 mutations, but that hasn't been borne out in more recent studies. And the most recent guidance really suggests that breast cancer isn't necessarily one of the cancers that we traditionally see in Lynch families. That doesn't mean that breast cancer doesn't happen in families that have Lynch syndrome. It's important to bear in mind that cancer can happen for lots of different reasons. And so people can develop cancer in a Lynch syndrome family, even if they don't have Lynch syndrome, for example, themselves, or they have Lynch syndrome and the breast cancer develops for other reasons. So you may still see breast cancer in those families, but it's unlikely that it's directly linked to the Lynch syndrome.
Okay. And is there any evidence about the skin cancer link at all?
So skin cancer, not sort of the types of skin tumours that you see, so not necessarily malignant cancers that you see, but usually they are what we call sebaceous adenomas. So they're a certain type of skin tumour that very, very rarely can turn into a cancer. But they are usually in people who people wouldn't necessarily notice them. Sometimes they can be very numerous, those types of skin tumours, and that's when it raises suspicion about it being Lynch syndrome. Traditionally, that was also referred to as Muir-Torre syndrome, which is a different sort of, it was thought to be a variant of Lynch syndrome. It's actually not a variant, it's the same condition. It's just that it's tending to present more with skin tumours in those people. We don't really tend to see melanoma in Lynch families, and you don't really tend to see basal cell cancers, for example, in Lynch families. So it's certain types of skin tumours, really.
Okay. We had a question from somebody who has already had a diagnosis of cancer, but they're specifically asking, if you've got Lynch syndrome and you've had a diagnosis of one type of cancer, does this impact your risk of getting another type of cancer in the future?
So it's very complicated actually, in the sense that there are lots of factors that will then influence that risk. But yes, if you've had a cancer, if you've got Lynch syndrome, you have an increased risk of developing those types of cancer. For example, if you have bowel cancer, you've had a portion of the bowel removed for the treatment of that cancer, the remaining bowel is clearly at risk and needs to be surveyed on a regular basis, as we would advise, which is every 18 months to 2 years. So there will be a risk even if you've had cancer, but there will be things that that will influence that risk. So the treatment that you've had already for those cancers, And also we, as I'm sure many people watching will know, we do recommend aspirin for individuals with Lynch syndrome. And the reason we do that is from the CAP studies that are run by Professor Sir John Byrne up in Newcastle, looking at aspirin as a preventative agent in Lynch syndrome. And we know that aspirin can reduce the risk of all Lynch syndrome related cancers by taking a daily dose of aspirin. So there are measures that you can use if you've had cancer to reduce your risk of a new cancer developing in the future. In terms of recurrence of a cancer, it's important to bear in mind that recurrence of a cancer that you've already had, that cancer coming back again, is influenced by the treatment that you've had for that cancer. So that will guide what your recurrence risk might be. And what Lynch syndrome is really more associated with is a new cancer developing in the body.
Brilliant, thank you. So we had a few questions specifically about family history patterns of different cancers and so on, and whether they're indicative of Lynch. So just to give you an example, one person sent in the comment that their mother died of what was described as stomach cancer age 45. They had ovarian cancer age 49. Her niece had a cancerous mole that spread at age 50, and she's asking whether she should be concerned for her daughter and granddaughter. So generally, if we could speak a little bit about what family history patterns crop up quite often, and whether something like that is something that where someone should be thinking about Lynch syndrome.
So I'd say that if you're at all worried about your family history of cancer, whatever the pattern might be, just seek advice from your GP. There are very clear guidelines around referral onto genetic services or onto family history specialist clinics. We've also developed an app at Guy's and St Thomas's, a cancer genetics app, which is for clinicians to use, not for people in the general public. But your GP could use that to assess your family history to make a decision about whether you need to be referred on. So for the person in question, I would recommend that she gets advice from her GP, and the GP uses a tool like that to make an assessment. In general, what we're looking at when we're thinking about Lynch syndrome is early onset cancers. So cancers that generally tend to happen, you know, the bowel cancer risk starts to rise from around 25 or 30 years of age, depending on which gene is involved. And so if you see young diagnoses of colorectal cancer in people's sort of 30s and 40s, that's obviously a flag. Ovarian cancer under the age of 50, endometrial cancer under the age of 50, those are the kind of things that a cluster of those types of cancer in the family will be the kind of things that we're looking for. The difficulty with just reported family histories is that we really need confirmation, because often, you know, it's not always clear necessarily whether a stomach cancer really was a stomach cancer, particularly in previous generations, or whether a gynecological cancer, what does that actually mean? And so one of our roles in genetics and in the family history clinics is actually getting that information and being certain that we are dealing with the type of cancer that we think we're dealing with. You know, we get histology confirmations, death certificates, those sorts of things to help make sure that we are looking at the correct pattern of cancer in the family and making an assessment based on a correct pattern.
Thank you. We also had several questions through about screening, which you've mentioned a little bit already. So if somebody knows that they carry one of these Lynch syndrome variants, what screening is available? So if we could break down for men and women of what they should be expecting to access.
Yeah, so it's very important, really, I think, for patients who have this condition to come through genetic services. It's very important that, you know, there is a lot of testing that's happening in the private sector, for example, but actually being referred by your GP into the regional genetic service for that sort of follow-up cascade testing in the family for other family members and for support for those individuals. I do think it's important that they have that kind of support from a genetic service. By doing that, it also means that you get the right screening put in place for you, or at least the right recommendations are sent through to your GP, so that your GP knows what they need to be doing for you regularly. For men and women, that again, it depends on the gene mutation involved, the exact gene as to what those risks might be, but generally 18 to monthly to 2 yearly screening with colonoscopies. Jo, can you still hear me?
Yeah.
Yes, sorry, I think it was gone still, so I just wanted to make sure. So 18 monthly to 2 yearly bowel screening is what we would put in place, and that's from either 25 years of age, usually from 25 years of age, but again, it depends on the gene mutation. So that has changed for PMS2 and MSH6 carriers. We have shifted that to later, and so from 30 or 35 years of age. And what we also would put in place is the aspirin recommendations, and that the dose of aspirin very much depends on the individual's weight. So for somebody who's under 70 kilograms, we would recommend 150 milligrams of aspirin daily. For somebody who's greater than 70 kilograms of weight, we would recommend 300 milligrams of aspirin daily. So it does depend. And also whether you take aspirin or not really does depend on other comorbidities and other medical problems that you may have. It's really important that we're not doing more harm by giving someone aspirin. So again, I would recommend that people have that conversation with their general practitioner or with the genetic services that they're under to make sure that they don't have any contraindications to taking aspirin. We also recommend that men and women have testing for a bacteria called H. pylori. So H. pylori is a germ or a bacteria that usually lives harmlessly in people's stomachs, and not everybody's stomach, but most, some people's stomach, and most of the time will not cause any problems. But in individuals with Lynch syndrome, it can increase the risk of developing a cancer in the stomach, and therefore we recommend that patients have testing to see if they carry that bacteria, and then they can have a short course of antibiotics to eradicate it. And then for women, again, depending on which gene they carry a mutation in, there are options for risk reduction surgery for managing the ovarian and uterine cancer risks. What we know is that, as we were talking about, the risks for PMS2 have actually changed, or we've learned more about them. And actually what we now know is that the risk for PMS2 of ovarian cancer is not particularly higher than the general population. So really the main risk is for endometrial cancer for PMS2 carriers, and even that risk is not particularly higher than the general population. It is higher, but not. Whether surgery is really what a woman would want to go down the route of is something for her to have that conversation with her clinician about, really. For MLH1, MSH2, MSH6, there are risks of endometrial and ovarian cancer, and so women can opt to have risk-reducing surgery to remove the womb and ovaries and tubes when they reach the correct age, or an age at which the risk is starting to rise. I'm sorry, there's a printer printing in the background, so sorry about the background. So yes, and so those are the main methods, and obviously we recommend that everybody is aware of their symptoms, that they put in place lifestyle modification to try and reduce their cancer risk in general, and obviously they take part in national screening programs when they're invited to do so as well. So for example, the survival screening program is really important that women take part in that, irrespective of whether they've got Lynch syndrome or not.
Thank you. That was really detailed, so hopefully that's really helpful for everybody watching. I know we covered very briefly just a moment ago about different family histories and so on, and you mentioned there's very much that indication of age of cases of cancer in your family at a younger age are more red flags for families to be looking at, and if they have those earlier cases of cancer in their family, then that's when they should go and speak to their GP and so on to ask about these things. So we had a question through from somebody whose mother died of ovarian cancer, but she's just actually found out that wasn't the case, that she actually died of uterine cancer rather than ovarian cancer, and that the two cancers that were actually separate, it wasn't that the one had spread from one place to the other. And this person has been told that although Lynch syndrome could be a cause, that her mother was 75 when she passed away, so it's unlikely to be something genetic. Now that lines up very much with what you're saying there in terms of age of onset of cancers, but quite understandably this lady's saying, she's been told it's not something to worry about, that she doesn't need to get testing herself, but is this something that maybe she should look into a little bit more, maybe look into more of a family history? She's just a little bit anxious, I think, about being told that she doesn't need to worry about that because she's got children and grandchildren.
So I think an older age at diagnosis of cancer is reassuring, in the sense that unfortunately cancer happens as we get older. It is a disease of old age, so we do tend to see those types of cancer happening in people's 60s, 70s and 80s. If somebody's been diagnosed with 2 Lynch syndrome related cancers, then I don't think it's unreasonable to ask advice from your GP. So if you have a close family member or you yourself have had 2 Lynch syndrome related cancers diagnosed, then it's worth exploring the family history in more detail, I think, and asking advice from the GP about whether there's any onwards referral that would be appropriate. But all genetic services have quite clear sort of referral guidelines around what the likelihood is of finding an underlying genetic condition based on a pattern of cancer in the family. So I think if there is any concern, then you can ask your GP to discuss your case with the local genetic services or the family history clinics, the family history clinics.
That's really helpful. Yeah. Thank you. You've discussed a little bit about risk reduction options, so the options of risk reducing surgery. We had a question in from somebody who says they have Lynch syndrome and they're considering a hysterectomy, but they're really unsure about going forward with it because it's such a major surgery and the risks and so on. So I wonder if you could fill us in a little bit, if you can, about kind of the risks and benefits of that surgery. I know it's a very personal decision for people whether to go ahead with that.
Yeah, it is a very personal decision. I think one of the positives, I suppose, about Lynch syndrome is that actually the cancers that develop in Lynch syndrome, they generally do have a good prognosis if they're caught at an early stage, and particularly with endometrial cancer, it is one of the types of cancer that does often present early with bleeding or gynecological symptoms. So that decision about having surgery is a very personal one, because I don't think we really have very clear data to say that risk reducing surgery for uterine cancer, for endometrial cancer, is better than symptom awareness, and we don't have very good screening per se for uterine or ovarian cancer. So it is, I think I would suggest that it's the kind of conversation that, again, genetic services can certainly help with. We have teams of genetic counsellors and geneticists, and our role is really to talk through that risk-benefit ratio, and it would very much depend on that individual. It would depend on whether they have other risks that might, other comorbidities or other medical problems that mean that the surgery might be riskier for them. If they have underlying heart disease or diabetes or other things that might mean that they're, in terms of an operation risk, there might be a higher risk, then those are the kind of factors we have to take into account for everything. So again, I think it's something that they need to seek advice about. With ovarian cancer, we don't have very good screening at all for ovarian cancer. It is harder to detect at an early stage, and I'd say that having the ovaries and tubes removed surgically is shown to reduce the risk significantly. So, but obviously that puts women into an early menopause. We then need to think about how we manage that for women, because obviously an early menopause in itself will have long-term side effects on that woman and that individual, in terms of her bone health, her heart health, her brain health. So it's always a very important balance to get right, and it will be a very individual balance that needs to be discussed with your clinician, really.
And I would say as well, I have a BRCA mutation myself, and I'm making these decisions as well. And I think for anybody watching, I think one of the best things you can also try and do is to speak to people making the similar kind of decisions and who've maybe had the surgeries themselves, find out, really what it's been like, what people have struggled with. Sometimes you actually find a lot of people saying, actually, it was a lot easier than I thought it was going to be. So I think that's a big part as well of making these decisions, is speaking to people who've been through similar. So we had a specific question. I know you've mentioned about aspirin when we were speaking about kind of actions we can take, but we had a specific question about what are the newest strategies to look after health and lifestyle for people with Lynch syndrome. So are there any particular things people can do day to day other than taking the aspirin when they have consulted their GP?
I think it's about general lifestyle measures that everybody mentions, really. We know that bowel cancer risk is associated with high red meat in your diet or processed food in your diet. So, trying to cut back on those sorts of elements of your diet, maintaining a healthy weight, not smoking cigarettes, maintaining a healthy, not drinking alcohol in excess. There are all these sorts of elements that I think are just part and parcel of everybody in the general population taking care of their health to reduce their risk of cancer. I wouldn't say that's any different for somebody with Lynch syndrome, to do on top of everything else that we offer for them, really.
Thank you. We had a question about aspirin, but I think we've already covered that. So the answer being, it's a good idea to take, but consult your medical team first to make sure there's nothing that's going to interact. I think that's a good one. Is that CAP3 study still recruiting people, or is that something that's no? Okay.
No, but we're still waiting for the results, and that'll be a while, but they'll be coming, I suppose, soon. Not soon, they'll be coming at some point.
Yeah. And from what I understand from that is what we're waiting on is, as you said, is we're confident that aspirin has a good effect in terms of reducing cancer risk, but we're trying to work out what the best dose is so as to not, take risks with medication, to kind of find the lowest possible dose. Is that right?
That's right. It's a dose finding study, yeah.
We quite often have questions around genetic testing, which are, like you say, there's specific guidelines for people if they are looking into whether their family history is something to worry about. Those specific guidelines in terms of whether they should be referred and whether they can access testing. But a really common question we have is in a family where there's significant family history and a family member who already has cancer, but that family member doesn't want to have genetic testing for all sorts of reasons, which we respect, but somebody related to them, say their child or their sibling, is interested because they're worried. Sometimes people say they're finding it difficult to access the testing because the person with cancer doesn't want to find out. Is that something that's across the board? Is that something that people still can go and find out about genetic testing, or does that person with cancer have to be tested first?
So always, ideally, it's the person with cancer first, but because that's the most informative way of taking forward investigations. But again, this is where genetic services have a lot of expertise in managing families where there might be difficulties like that, and we can think around different avenues for offering testing. So I think the important thing is that if people are concerned, they come forwards, they ask advice, and if they're referred to genetics, we can explore. Sometimes it's we can work with the family, and that's our area of expertise, really, is all around family communication and how we deal with those sort of difficult conversations that sometimes need to be had. And if we are finding it difficult, sometimes there might be someone else in the family who's had cancer where we can explore through that avenue instead. Or if we really are stuck and we aren't in a position to be able to take forward investigations in someone with cancer in the family, but we have a very high suspicion that this is Lynch syndrome, then we can discuss those cases in more detail and come to a decision about whether any testing for other people in the family is possible. Obviously, that's a last resort, really, because actually, in terms of testing the person with cancer is the most, firstly, it's the most informative way, but also it's a least ambiguous way of taking forward testing in the family. So it's the best way of getting answers without creating more questions, if that makes sense.
That makes a lot of sense, thank you. I know you mentioned there about kind of expertise with dealing with families and so on. It's something that crops up quite often, and we're actually doing another session this week about how to speak to family members. So if someone is particularly worried about talking to family members, just to be 100% clear, whose responsibility is it to pass on the genetic testing information to families? Is that something that the NHS helps do, or is that a responsibility of the family members themselves?
It's always been something that the family members are encouraged to do, because of the difficulties, really, for genetic services to be facilitating when we don't even know who those family members are. So it's very much something that we encourage family members to do, and we can make it as easy as possible we often provide a letter which people can pass on to their relatives to say there is this condition in the family. It doesn't need to have any patient identifiable names on it, but it will just have the reference number for the family, for example. And again, if people have concerns about passing on that information, that's exactly what we're here for. And we have our genetic counsellors are trained in the sort of psychosocial aspects of dealing with genetic conditions. So it's always better to ask, and we can help rather than maybe not pass on the information for fear of creating issues in the family, because this is all about protecting you and your family's well-being in the future.
Absolutely. A question that crops up quite often in terms of genetic testing is, what age should people get their children tested? Is this something that is a specific age, or is it when they're ready?
Yeah. So for conditions like Lynch syndrome that are adult onset in terms of their risks, we suggest that children aren't tested, and that actually it's from adulthood, so from 18 years onwards, that that individuals can have predictive testing. So that's where they have testing for a mutation that's already known about in the family. And the reason we do that really is to protect that individual's autonomy and their right not to know information. It's really important that they are engaged in that conversation and that they make that decision at a time that's right for them. And 18 might be right for one individual, and actually never knowing might be right for another individual. And we need to respect that right of everybody. So that's why we offer testing from 18. I'd say not everybody takes it up at 18 at all, because obviously we don't put screening in place for Lynch syndrome until 25 at the earliest in terms of the bowel screening. So for some people in their late teens and early 20s, they're not ready to know, or they would rather park it and come back to it at a later date. So again, this is something that we spend time with, talking through with people through their genetic counselling sessions as well.
Thank you for that. We just had a question through about the Protector study. I don't know if you have many details about that. It's something that I've heard of before.
Mm-hmm. Yeah, so the Protector study we're recruiting to it, guys, actually, and it's a study looking at risk-reducing removal of the fallopian tubes with delayed removal of the ovaries. And this comes back to what I was mentioning about the risks and benefits of removal of the ovaries and tubes and the issue of an early menopause. We really don't want to be doing more harm than good to people when we're doing these procedures. And so the idea of the Protector study is really to try to retain the hormonal function of the ovaries up until the age of natural menopause, but reduce the risk of ovarian cancer. Now, this is based on the premise that it's based really very much on the BRCA carrier population of women, where we have a lot of data to suggest that the ovarian cancers actually don't arise necessarily in the ovaries, but arise in the fallopian tubes and then spread to the ovaries. Not in all cases, but in a majority of cases. And so the idea being that if you remove the fallopian tubes, you will be reducing that risk significantly of ovarian cancer, but you won't have the detrimental side effects of an early menopause. Yeah.
That makes a lot of sense. I think that's something that's really interesting for the kind of the communities to find out about going forward and get involved in. We do actually have Ranjit Manchanda, the leader of the study, doing a session for us in August. So if anybody watching is interested in finding out more, both what the study is, how to get involved and things like that, please have a look on our website, because you can ask him every question under the sun and how to get involved in that then. So a question that quite often comes up in kind of discussion groups and so on about Lynch syndrome and BRCA in general is about the options around having a family, and whether there's anything available through the NHS for people who don't want to pass on the faulty genes that they know they have.
Mm-hmm. Yeah, so actually, guys, we're one of the main centres in Europe for a technique called Preimplantation genetic diagnosis, or PGD. So PGD is where couples undergo IVF treatment, and then the resulting embryos are screened to see if they carry the familial genetic mutation or not. And we've been offering PGD for many different conditions for a few decades now, I'd say about 15, 20 years. And we are able to offer it for Lynch syndrome, depending on the gene involved. Each condition that we offer PGD for has to have a license in place from the Human Embryology and Fertilization Authority, so the HEFA. And there's been some contention around PMS2 in terms of whether PGD is something that we would recommend or not, because we now know that the risks are much lower for PMS2 carriers than previously. But this is a conversation that's happening at a national level, really. But PGD has been something that we have been able to offer. In terms of other reproductive options, For a lot of genetic conditions, we can offer prenatal diagnosis, but prenatal diagnosis is when you test a pregnancy, an already established pregnancy. And that, again, is something that would only be sort of discussed really if there was a feeling that you would terminate the pregnancy, if you found that the baby carried that mutation. And I think for conditions like Lynch syndrome, BRCA, prenatal diagnosis again is something that divides people really in terms of whether it's an option or not, because we can put measures in place to prevent the cancers that take place. Prenatal diagnosis has often been used in conditions that have that may be life-limiting or very severe childhood conditions traditionally. But that's not to say that it wouldn't be something that would be discussed. Some places do discuss prenatal diagnosis for these conditions as well.
Thank you. One question that crops up quite often, and I've actually seen on some forums just today actually, is trying to get things like insurance, life insurance, critical illness insurance, and mortgages, and people worried about being able to do that based on genetic testing results. Is this something that people need to worry about kind of before they get a genetic test, or worry about impacting their future financially at all, do you think?
So in terms of insurance, there's a moratorium in place between the insurance companies and the government that's been in place for as long as I've been in genetics, and before then really, saying that insurance companies are not allowed to ask about the results of predictive genetic testing unless it's for one specific condition, Huntington's disease, and it's over a certain amount of life insurance policy that people are taking out. So actually, in terms of Lynch syndrome, you do not have to declare your genetic test results at the moment in terms of the moratorium that's in place. That doesn't have an end date at the moment. It used to be that it was being renewed every 3 years, but it doesn't currently have an end date anymore. But of course, you do have to declare your family history of cancer when you're taking out insurance, and that will be something that you would need to make clear. And you are able to, if you wanted to, tell them about a negative predictive test result, so where you've been found not to carry the mutation, that might actually be helpful for you. So there's quite a lot of information that can be found on the Association of British Insurers website, so www.abi.org. That's the website that you can find out a bit more information about it.
That's really, really useful, thank you, because that kind of practical side often comes up. So I know we've spoken a little bit about kind of talking to family members and so on. So someone specifically asked if they have Lynch syndrome, what's the chance that their siblings have it, because they don't have a very good relationship with them, and they don't want to have a sit-down conversation with them that's potentially going to be a bit difficult unless they absolutely have to.
Yeah. So it comes back to what I mentioned at the beginning about how these gene mutations are inherited. So back to biology lesson, you have 2 copies of every gene. So you have one copy that comes from mum and one copy that comes from dad. And what we know is in somebody with Lynch syndrome, they have one normal copy of the gene and one with the mutation. So they would have got that mutation either from mum or dad. So that means that when mum or dad had their sibling, they would have either given them the normal copy of the gene or the one with the mutation. So if you have Lynch syndrome yourself, there's a 1 in 2 chance that your sibling or that your child might have inherited the mutation as well, so 50-50 chance. Like I said at the beginning, it doesn't mean they will develop cancer at all, it's just that they will be at a higher risk. And so it is quite a high risk, I suppose, of passing on the mutation and of your sibling being affected if you have the condition. And I would encourage, again, if there's difficult communication issues in a family around conveying that information, then again, that's what the genetic services are here to help support people with.
Thank you. I think that's really useful for people to know. So we've just had a specific question through about treatment when you know you have Lynch syndrome. So as we, lots of us know, if you know you carry a BRCA mutation, that can inform your treatment in terms of specific medications that you can take, such as PARP inhibitors. Is there anything like that around Lynch syndrome, where the knowing that you carry a mutation can inform the treatment of the cancer that you have?
Yeah, absolutely. So immunotherapy drugs are relatively, well, they're not that new anymore, but they are a type of drug that modulate the immune system, and they've been shown to be very effective in Lynch syndrome related cancers. So it's certainly something that if people have a diagnosis of cancer themselves, are being treated, it's worth them asking their oncologists about whether immunotherapy is something that would be considered. It's definitely something that's used for individuals who have those types of cancer.
Thank you. So I know you've spoken quite a lot about screening in general. I know recently there's been a kind of a lot in the news and so on about screening appointments kind of not taking place with everything that's been going on. Is this something that people need to be worried about? Do we think that screening appointments are going to be getting back up to speed for people with Lynch syndrome, so for example their colonoscopies and so on?
As far as I'm aware, things are getting back up to speed, definitely. And you know, unfortunately COVID hit everything across the NHS in a big way, and screening was definitely one of the areas that was also affected. But I'd say that things are definitely getting back up and running. I think if you are beyond your screening date, so that 18-month to 2-yearly period, if you're sort of nearing that 2-year mark, then it's really important to sort of flag this with your GP or your oncology team or whoever, specialist that you're under the care of, so that they can make sure that you do have that screening on time. Obviously, the priority has been diagnosis for people who have symptoms that are very suspicious for cancer, but that doesn't mean that screening is not getting back in place. So hopefully that's happening now in a lot of places.
And definitely worth saying that whether we carry a faulty gene or not, it's definitely the message that if we have any symptoms whatsoever that we're worried about, is to go and speak to somebody. Don't worry about, it's not the case that we'll be overwhelming the GPs or anything like that. Just make sure that we make an appointment. It might be a telephone appointment or something like that, but it's definitely worth speaking to your GP and not to wait, because those referrals are still happening, aren't they? If there's
absolutely, and we want to encourage people to use the NHS like they were using the NHS. Don't be fearful of going and speaking to your GP or having a telephone appointment with somebody, because it's really important that we, COVID is there, but we also need to be thinking about all the other conditions that we still need to be dealing with. And it's important that if you have symptoms, that you're worried about symptoms, that you do seek advice, definitely.
Absolutely, so thank you. We've got through all of our questions, which is brilliant. So that, I think that's really, really helpful, that hopefully everyone on the call and people watching who couldn't make it have been able to have their questions asked. So that's absolutely brilliant. I wonder if there's, a kind of a closing few words that you might have, Anju, about Lynch syndrome, and maybe an advice that you'd give to people when they find out that they carry Lynch syndrome.
So I think the main thing to say is that reiterate a few of the issues that we've talked about, is to say, if you're concerned about your family history of cancer, if you're worried that there might be Lynch syndrome in the family, please do get advice from your GP about referral onto the correct services. If you have Lynch syndrome yourself, then there is lots of support available through genetic services, so please make sure that you are plugged into one of those services. So for example, at Guy's Hospital, we have set up a multidisciplinary specialist service for Lynch syndrome patients, where we have a clinic that people can attend, obviously remotely at the moment, but to get advice from the different specialists that might be involved in their care. So there is a lot of support, and just come forward and sort of take charge of it for yourself, and make sure that you are getting advice and opinions whenever you have questions, and don't feel frightened to do that.
I think that's a really good message, that we can take that knowledge and we can do something with it, and like you say, not to be frightened. We can use that knowledge to hopefully reduce our risks, to take a bit of control, and to ask for help when we need it.
Yeah, completely. See this as I think it empowers people, this sort of knowledge. It might feel scary at the beginning, but actually it's very empowering for that person and their family to know why there is this history in the family, and what they can do to change that pattern for future generations as well.
Brilliant. Thank you so much. I found that really informative and really enjoyable. So thank you so much for helping
You're
us
very
out.
welcome, Jo. Yeah.
We'll send around a quick survey afterwards to everybody who's on the call so that you can let us know how you found it. And as I said, if anyone ever has any more questions about this topic, you can always get in touch with us on our website, info@ovarian.org.uk and ovarian.org.uk online. And, you know, we've got lots of information on there. As I say, always come and ask questions of us. We can hopefully advise you as to who the best person to speak to. As Anju was saying, is there's lots of people out there on the NHS who are, you know, there specifically to help us and answer our questions and support us. So thank you so much again, Anju.
No problem.
And thank you everyone for joining, and hope to see you again soon.
Thanks
Bye
a lot.
everyone. Thank
Bye.
you.
Bye.